Can everyone hear me? Oh, they can hear me or not. My name is Sandra Smith. I'm the inpatient director at Salem Township Hospital, and I have with me Janell Wilkerson, who is our infection control officer. So we have a presentation today for an antimicrobial stewardship within our hospital. Within our hospital, our stewardship program is a coordinated program that ensures the optimal selection, dose, and duration of antimicrobial therapy that leads to the best clinical output and outcome for treatment and prevention of infection while producing the fewest toxic effects and the lowest risk of resistance. Our program is through a committee which has multidisciplinary work groups that reports through the pharmacy and therapeutics, or a similar hospital committee on a monthly, bi-monthly, or quarterly recurring schedule. It's charged with the responsibility of promoting optimal antimicrobial utilization. The purpose of the stewardship was to make sure that the appropriate use of antimicrobials were being used by selecting the appropriate agents, dose, duration, and the route of administration, so we could improve the patient outcomes while minimizing toxicity and the emergence of antimicrobial resistance. We were going to improve the stewardship practices at Salem Hospital and to monitor the outcomes and the use throughout, which comes with a report with which antibiotics are used, and also if we've had any fallouts. The Salem Township Hospital Antimicrobial Stewardship Committee, they meet with the pharmacy and therapeutics meeting. The same team participates in both committees. Our committee consists of an administrative or leadership champion, an antimicrobial stewardship program leader, a physician leader, which is our ER physician, the pharmacist leader, infection prevention and control personnel, and IT if we need support with any meetings or information that we need to set out. The objective of the program is to improve patient outcomes through optimization therapy by selecting the appropriate antibiotics, the dose, the route, and the duration. We're hoping to improve patient safety by decreasing side effects, support the education of all healthcare providers, patients, and their families, minimizing the development of any resistance by selecting the appropriate antibodies, reducing the length of their stay, and any patient-associated hospitalization cost. We plan to control C. diff infections and the emergence of multi-drug resistant organisms. It is essential within this program that it is coordinated effect among multidisciplinaries. Everyone's understanding of the why is imperative to a successful program.
Some roadblocks that have been found is limitations of the electronic health record system, limited functionality at the order entry. Some examples were unable to require a diagnosis and the days of therapy, manual data collection, and the provider acceptance. It is imperative for the success. The Stewardship Committee's responsibilities was to be compliant with the HFAP and Centers of Medicare and Medicaid conditions of participation related to antimicrobial stewardship, coordinating among all components of the hospital responsibility for antibiotic use and resistance, including the infection prevention and control program, the quality assessment and performance improvement program, the medical staff, nursing services, and pharmacy services. Documentation of the evidence-based use of antibiotics in all departments and services of the hospital. Demonstration of improvement with proper antibiotics such as reductions of C. diff infections and antibiotic resistance throughout the hospital. development or revision of existing policies, procedures, protocols, and guidelines related to infectious disease. We had to adhere to the nationally recognized guidelines as well as best practices for improving antibiotic use. Reflection of scope and complexity of the hospital service provided. Development and distribute an antibiogram at least annually, assessing trends of antimicrobial resistance within the facility. Provide recommendations to the Pharmacy and Therapeutics Committee about antimicrobials. Provide education in the form of newsletters, in-services, and one-on-one interaction to providers regarding initiatives. Educating the families and the patients regarding appropriate use of the antimicrobial and antibiotics. Collecting, tracking, and analyzing antimicrobial consumption through examples of days of therapy and purchasing costs. Reporting regularly antimicrobial stewardship measures to relevant healthcare practitioners and hospital administration. The CDC core elements of hospital antibiotic stewardship program recommendations were documentation. This in the medical records or during order entry, looking at antibiotic indication, antibiotic dose, duration of the antimicrobial therapy, and review of the appropriateness of all antibiotics that were prescribed after the 48 to 72 hours from the initial order. Pharmacists were required to perform interventions approved by the Pharmacy and Therapeutics Committee, such as the IV to PO conversion of antimicrobials, renal dosing of the antimicrobials, therapeutic interchanges, antibiotic streaming, and antimicrobial restrictions. Pharmacy, microbiology, infection control personnel, and information technology contribute to the stewardship program by guiding the proper use of the test and the flow, collaborating to ensure that the lab presents data that supports the antibiotic use, development and education, facility-wide infection surveillance, prevention, and control policies and procedures that adhere to the guidelines, competency-based training and education through the hospital, prevention and control of hospital-acquired infections, and creating props for action to review antibiotics in key situations and help to collect and report antibiotic use. The Stewardship Committee reports on the following: pharmacist interventions including the IV to PO, renal dose, and de-escalation, multiple drug resistance organism trends, and antimicrobial spend trends.
That is our presentation. Our hospital is a small rural hospital, so we do have to collaborate with all departments and physicians here just to make sure that this works within our facility. Do you have any questions? Well, we appreciate your time. Thank you.
Good afternoon, everyone. Can you hear me? My name is Michelle Spainhour-Luhrsen. I am a registered nurse at Kirby Medical Center. I'm the Director of Quality and Infection Prevention. And I'm going to just tell you a little bit briefly about how we have done our antimicrobial stewardship program. We're a small rural hospital with a rural health clinic. We have 16 inpatient rooms, and we have about 9 ER patient bays. So for us, it's been a little bit of a journey. We also have in our rural health clinic 4 physicians and about 8 nurse practitioners and PAs that go to 3 different rural health clinics. So as you can see, I will hopefully share my screen with you and show you. So first off, why do we need the antimicrobial stewardship program? Well, the big reason for us is we really wanted to make sure we were doing the appropriate use of the antimicrobials. We wanted to keep costs down. We wanted to make sure we were meeting CMS and Joint Commission guidelines. We didn't want to have all those resistant bugs out there that are happening everywhere. We have a very low infection rate here at Kirby, and we wanted to be able to keep it that way. So it was important to us to get this started. So we started it with our leadership team. We have an amazing executive team, and we had our chief medical officer on board who is over our clinic, 3 clinics that we have, myself, the infection prevention department. I have 3 others on board with me. We have our pharmacist, where we are now have, I think, 4 pharmacists that do our retail pharmacy and inpatient pharmacy. They're very big into the program. We have clinical informatics department that helps us and has been able to create multiple reports and things that we need. And then we have clinical leadership, our CCO and our COO, who is also a nurse. They have been very supportive and on board. We've been able to engage our hospitalists and our ER physicians, but our hospitalists, one of the things that we did to help engage them was I report to them every month what patients got antibiotics while they were either in observation, swing bed, or an acute inpatient, and they have to meet 3 different indicators. They have to meet the indication for the antibiotic, the projected duration for the antibiotic, and the goals for those antibiotics. So those are 3 things that we measure, and it gets reported to our state or to our governing board, and we actually have it as an incentive for them that they don't get all of their monies if it's not done. And the providers had the input on this. They knew what they wanted to do and how they wanted to do it, so that's what we did. When we started off small but thought big, we knew we needed to do the inpatients. After we got that on board, we moved on to our ambulatory areas. So how did we get there? Well, all of our antibiotics require a clinical indication for use. Our clinical informatics team was able to build into our EHR a hard stop. So that hard stop made it have a date for when it was done. They had to have the clinical indication, and we put in that auto stop, which I've got up here for you to see, of when that antibiotic would be stopped. So if it's an infection, they have 14 days. Empiric therapy, only 3 days, and then they've got to get it changed. So it was really kind of nice. The pharmacy and the physicians worked really closely together to get these dates and auto stops done. I personally review all of our cultures. So once we have a culture done, whether it's in the ER, in the hospital, or the clinic, they all get routed to me. I review them and make sure they've been put on the correct antibiotic from the culture and sensitivities. One of the things that we did is we didn't want to have those unintended consequences. So renal failures, the HAI. So I look at every patient every day in the hospital. If they're on an antibiotic, I'm talking with the pharmacist, and that pharmacist also goes around and talks with the physicians and with the patients. We implemented what they call medical food protocols. So we do pre and probiotics to help with UTI prevention. Our physicians will order that when they order the antibiotics. It's one of those that can default for them. So some of the things that we do is we review those antibiotics within that first 48 to 72 hours to make sure they're on the correct one. Our pharmacist and I do multiple disciplinary rounds with our hospitalist and the nurse and the tech on the floor. So we see each patient every day that's acute, every 3 days, the swing bed patients. And we're looking to see, okay, what are they on? What antibiotics should they be on? Are they on the ones that treat the same infection? Should we tweak that and put them on a different infection? We put posters in the ER and in the exam rooms of the ambulatory clinics that stated, if you have a virus, you do not need to have an antibiotic. If you have a bacterial infection, you may be given an antibiotic. And they were from the CDC and from ICANN, and they're just amazing posters that really got patients talking and questioning and wanting to know. We also handed out little pamphlets into any prescription that was given or in their after visit summary information that would say, here's what is for a common cold, here's what's for the flu, here's what's for a bacterial infection, and here's what's for a viral infection, to give the education to the community and get them on board. So what we measure and track multiple things. We track our HII rates. We track antibiotic use per 1,000 patient days, annual review of most frequent identified infections. We track the in-house antibiotics prescribed, like I said, the indication, the projected duration, and the goal. When I do that, I give them percentages of how well they've done. I review 27 charts 1 month that they were able to hit the indication, the projection, and the goal on everything. We have currently just been doing that on our inpatients. We do not look at the ER patients on a regular basis. I just am starting that, and the ED physicians have already been really good at that, but we're trying to get them some numbers. For the ambulatory clinic, we go through, my team and I, and look at all the antibiotics prescribed while the patients have been through the ambulatory clinic. And if it was prescribed for a upper respiratory infection, we look at that and take information back to them of when it was prescribed, how long they prescribed it for, did the patient come back for follow-up, or if they, we also look at patients who possibly could have gotten an antibiotic but did not because the symptoms were so vague, but we use the diagnosis codes and we go back and see if they came back in or if they called back in to see about getting an antibiotic. So we look at that really closely in the clinic. We have a champion PA who we work with, and she's phenomenal at getting the information dispersed to the other practitioners and help us keep those on track. So one of the things that's really important that I found is making sure that you use your resources for your antimicrobial program. You know, participate in organizations that are out there, like the Agency for Healthcare Research and Quality Safety Program. We did a huge project with them for ambulatory care that kept us on board. The Center for Disease, CDC, making sure that you're using that. They have the core elements of hospital antibiotic stewardship programs. Amazing program, a lot of information there. You can pull those posters and use those posters to put throughout your organization to educate the lay person that's coming in for an appointment, helping them to understand why or why not they're going to get the antibiotic. That was one of the big things, was trying to help educate the community that just because they have certain symptoms does not necessarily mean that an antibiotic is a definite given. So that was very, very helpful for us. We also developed our policy that states all of these things so that everyone in the organization is aware of what we need to do. And it has all of our members on there when the hard stops are and that information so that it can be reviewed and looked at any time by anyone. The lab has been very involved as well. They do our antibiogram for us every July. So we're getting ready to do our next antibiogram. Our pharmacist and I have a copy that we keep with us and we look at to make sure we're on track with everything. The big thing is making sure too for giving feedback. Share with your providers. Let them know, hey, I've noticed that you've done this antibiotic for so many different patients, but then you switch, now you're doing something different. Is there a change in your practice that's going on? Are we seeing trends of certain providers only ordering a certain antibiotic when it's not the appropriate therapy? And like I said, we report it to our governing board. So my CCO who I report to every month, takes to the board the metrics of how our physicians and practitioners are doing on antibiotic prescribing. Are they overprescribing? Are they prescribing the right medications? Are they putting that duration in there? Are they making sure that there's a goal of how long they want them to stay on it? Do they turn it off and switch it over to oral antibiotics within so many days if they can in the hospital instead of keeping them on IV antibiotics? And that seems to really work well for us. Our physicians have really gotten engaged and want to do what's best. So they've been very helpful for us with that. And that is what I have for you guys. Is there any questions that I can answer? I don't know if anyone's out there. I'm hearing a lot of crickets. I know it's been a long day, and I appreciate everyone who has come on to the conference. There's some great information. Like I said, small rural health and critical access hospitals, so we don't have as much information as some of the others, but you are getting a little bit of time back, and hopefully you can go into another session if you'd like and catch up on someone else. Thanks for your time. I appreciate everyone being here.
Or if nobody has any questions, and if our presenters can hang out a little bit, maybe somebody wants to share a little bit about their stewardship program, since it is so difficult with rural hospitals. Maybe this would be a good time to just bounce ideas off of each other and get a little bit of feedback or just a little bit of support. And I see that Lauren Howell had a question. Sorry, it just jumped away. Lauren asks, what tools do you all use to collect the data you're reporting? Does your EMR gather those statistics? For example, your IV to PO conversions.
Hi, this is Michelle Spainhour-Luhrsen from Kirby Medical Center. Our EHR does collect a lot of the data for me. Our clinical informatics have made multiple reports for me, so I can pull all of the antibiotics that were prescribed by a provider in our ambulatory setting. I can also pull the antibiotics that were prescribed in the hospital and that were converted to PO. So we're very lucky that our EHR system is very useful for us with the clinical informatics team building those reports and giving me that information to look at.
I see another question in the chat from Rachel. How do you maintain stewardship activities when your hospital has limited staff resources?
That's a good question. It is hard to do if you don't have the resources there. Really, the first key, I think, for us being a small hospital was that our administrative team was very much on board. They really put forth the effort to get the support needed to do this. They know it's one of the initiatives we need to be diligent on. So it's been one of the things I've been able to keep on top of. But it's also because I've got those resources in the EHR built for me, and I have the pharmacist who helps with it as well. But it really starts with getting your leadership team on board and them seeing how important it is so that you can get the resources needed.
Yes, I definitely agree with you, Michelle. Obviously, I'm not in a clinical setting, but I've worked on antimicrobial stewardship projects, and just getting leadership support is the key to getting any sort of stewardship project off the ground. And that's definitely an obstacle that a lot of people have to overcome. So hopefully in the future, with more events like this, we can raise awareness and hopefully help overcome that. And then I see another question in the chat from Alexis. She said, what kind of standing orders do your hospitals have? So I'm not sure who wants to take that one, Michelle or Sandra.
This is Michelle again. We have multiple standing orders that start in our ER, and it allows the physicians to be able to do certain antibiotics with certain order sets. So we have empiric therapy aligned with pneumonia order set, or we'll have it aligned with a sepsis order set. And it's something they can do, but it has to be reviewed within 24 hours to be able to be switched over to something else. That was one of the parts of our policy, as we built those in so that the physicians could quickly go to something and then get it changed over within 24 hours, because it all has to be signed off on by one of our pharmacists.
I agree with Michelle. One of our designated people who is on our stewardship program is our ER physician. So she has helped formulate a standard policy with pharmacy and the other directors, just to make sure that it starts in the ER, so we can kind of head it off before they get up to the floor.
I'm not sure if you guys can see the chat on the side, so I'm happy to keep reading the questions, but feel free to interrupt me if you find one that you want to answer. Jordan is asking for Michelle, what EHR does your facility utilize? Also, we have a limit length of stay for many of our medical patients. Many stay on IV until discharge. Do you have many convert to PO and stay IP?
Hi, Jordan. Thanks for the question. Our EHR system that we use is Meditech 6.15, and we're getting ready to switch over to Meditech Expanse. Our clinical informatic team consists of 5 different people. One is just for building reports. So it's been very useful for us as a overall organization. For our inpatients, yes, they stay on IV antibiotics very limited. We try to have them switched over within 3 days at the longest. Our physicians go in every day, see that patient with the pharmacist, and they talk about when can they switch it over and how quickly can they switch it over to the PO. So we do not keep a lot of people on IV antibiotics.
Okay, Kim replied, yes, our pharmacist was on board right away, which helps very much. And with our chief medical officer, our AS committee also includes the lab director, DON, ADON, and infection control. We were able to get going with the plan right away. So that seems to emphasize your point, Michelle, that leadership support is so important for stewardship. Does anyone else have any questions or want to share anything about some challenges they've encountered with their stewardship programs? Maybe how some techniques, how you're able to get leadership on board? A lot of comments saying great presentation, ladies, and I definitely agree. Andrew said he would love to see some data from your pre and probiotic protocol if you have it. Very interested in learning more. And I see we still have quite a few viewers, so please, if you have any questions, put them in the chat. But if you don't, you're also welcome to go and join one of the other sessions that is going on right now. These concurrent sessions run until 2:30. But you're more than welcome to stay here as well and chat with us.
Hi, it's Michelle again. I just finally got the questions to come up. But one of the things that is really, I think has really been important for us getting those patients off those IV antibiotics is having our pharmacists go around with the hospitalist and looking at why are they on IV? Can they be switched over? How quickly can we do that to get the right treatment plan going for them? Myself also looking at, the culture reports, if they're done, and being able to share that information quickly with the team so that they are really looking at what's the best route for this patient. Obviously, sometimes we can't switch to PO, but we really are switching within usually the next day. They're trying to get them on PO, if not the second day. So that pharmacist definitely plays a big part in that for us.
Okay, thank you so much, Sandra and Michelle, for those presentations. They were wonderful. I'm not seeing many more questions. So if everyone wants to, jump onto another session and learn a little bit from the other tracks, I'm not going to stop you from doing that. But thank you guys so much for everything. Rachel just asked a question. Does anyone have any recommendations for rural hospitals that have limited on-site pharmacist hours? She also would love to hear about successes with leadership engagement, which I think we would all love to hear about how to successfully engage leadership.
Hi, it's Michelle. For the first part, when you don't have a hospitalist or a pharmacist on site very much with hours, we partnered with a bigger hospital about 30 minutes away from us, and they had multiple pharmacists on board, and we were able to speak with them pretty much anytime, 24/7. So the ER physicians worked with them, hospitals worked with them. We were able to call and get information and change things up. We actually did a PI project or PI study so that we could see how quickly the pharmacist at the other facility was signing off on orders and making changes to orders that were needed so that we could keep them involved. So it's really important to build that relationship. If you don't have someone in-house, build a really good relationship with those that are doing your backup support for pharmacy. Leadership engagement, that was something that I'm very blessed at my facility. My leaders, I take something to them, they're pretty much on board right away. They want what's best for the patient. They really walk the talk, so to speak. So for me, it was not hard. It was just saying, hey, we need to do this. These are the things that are coming down. Here's what's happening. And they were on board immediately with me.
Thank you so much for sharing that, Michelle. Sandra, did you have anything you wanted to add? You might be having some trouble getting off mute, or maybe you just don't have anything to add, which is totally fine too. Are there any other questions? Feel free to put them in the chat. If not, you're welcome to go join another session or just get up and stretch your legs. I know sitting for a long period of time could be tiring. Okay, a question just came in from Jordan. We were submitting data to NHSN AU, however, it was time consuming and difficult to collect this data with our current EMAR. Do either of your facilities submit to NHSN AU? And if so, how do you utilize this data? That is a great question. So Michelle or Sandra, do either of your facilities submit to the NHSN AU option?
Hi, it's Michelle. Yes, I do report to the NHSNAU. It is a little difficult maneuvering through it and getting the information. I have not utilized it as much as I should just because of the pandemic, and that was kind of one of the things on my back burner. We just started doing it before the pandemic hit, and I've not really gotten back into it.
Yeah, that's definitely understandable with all that's been going on. So it looks like Tamara asks, my pharmacists are the lead in our antimicrobial stewardship program, reviewing indications, culture, and sensitivity reporting, changing to PO for those medications with similar bioavailabilities immediately, etc. Very open conversations with the hospitalist to change from IV to PO within 48 hours, and if not, documentation of reasoning for not making that change. Multidisciplinary meetings daily with all services to discuss continuing need for antibiotics. So kind of not a question, but definitely a statement that adds to our conversation that we're having and definitely emphasizes the importance of a multidisciplinary team. One person really can't do it effectively alone. So thank you for sharing that, Tamara. Okay, so I'm not seeing any new questions again, so just another reminder that feel free to go ahead and have a little break right now. The next session begins at 2:35. You can hop into one of the other breakout sessions to catch the ending of their presentations, or you can just relax until 2:35. But thank you all so much for joining, and thank you to our presenters. That was an excellent presentation. I think we can all agree on that. And so thank you all so much, and I'll see you in the next sessions, hopefully.